screen on there.
So, oh, when I do my
Yeah.
flip chart. Get it up in a couple seconds. Okay. Do you know how to troubleshoot?
I'm sorry?
I said, how good are you at troubleshooting?
Oh, okay. So if you download, yep. And then save.
Oh, save it.
Yeah, I think couldn't be downloaded. Interesting.
Good. Thanks, Dave.
Yeah.
All right, so we'll go ahead and get started. Sorry about the slight delay. Came over from the interviewing season. Just going well. We have a lot of good candidates if anyone's interested in knowing. But for the next 45 minutes, I'm going to talk about ECMO for ARDS specifically. When I was making this lecture, I went back and forth between putting a question mark at the end of ECMO for ARDS because there are ultimately three different camps of people. There are people who believe wholeheartedly in ECMO, VV ECMO for ARDS. There's a camp that says, you know, it doesn't work, there's not enough evidence. Then there's people who are in the middle. So what I'm going to attempt to do over the next 40 minutes is to answer a few questions. I'm going to talk a little bit about how ECLS, or extracorporeal life support management, began. I'm going to answer the question about some of the evidence supporting VV ECMO for ARDS. We're going to review the circuit components of VV ECMO, and then I'm going to answer how can I apply this in the medical ICU setting. And we're going to do that through working through a clinical case that our ECMO care team saw. So generally this lecture, I don't want to say generally, but last year we gave it in a small group setting. I think that's important because our group, our ECMO care team, we see in 2019, I'll talk a little bit about this at the end, we saw, was it 19 patients over the course of the year. So you can imagine that, 17 or 19, we'll see. But you can imagine that you may go a year with not interacting very much with these types of patients. So it's very important that you put yourself in the mindset of kind of working through how you would address certain complications or how you would address the management as a whole. So because we're not doing it in a small group format, I'm going to encourage you all to participate. I'm going to ask questions so it can be interactive with the whole group that's here. And what did Dr. Buckley use this morning? Jack used the WAIT method. What was it? Was it WAIT learning?
Yeah.
Yeah, so we're going to do that. And we'll double it probably. I'll give you guys plenty of time to think through. All right, so just a plug for the ECMO care team. For those of you who aren't aware, some of the first years may have only heard it in passing. This is the specialized group of intensivists that care for our patients that are placed on ECMO. You can consult us via Halo. We're always here. Our ECMO patients, when they're cannulated, are placed on P5, and that is due to nursing. The nursing training on P5 allows them to care for these types of patients. There are different models for ECMO. You can have respiratory therapy, nursing. We here have a perfusionist model, meaning the perfusionists make changes and things like that to the ECMO unit. And we're in the process, we've submitted our application for ELSO accreditation, and we're in the process of obtaining that. That process can generally take a couple of years. It's just data gathering and what we're doing, and part of that, or what we're doing right now, didactic sessions, education, and then reviewing our patient outcomes. So in these few lectures I've given, I'd like to talk a little bit about the history. So I think it's important. Number one, I think it's interesting. Number two, I think it's important to see how far ECMO has come since the beginning. So this is Dr. Gibbon on the picture on the left, and Dr. Gibbon and his wife Mary on the picture on the right. I put the picture with Mary and Dr. Gibbons because in the 1930s, it's not easy for a woman to get put into a medical textbook. And they always call her a collaborator. But if she's put in a textbook in the 1930s, my guess is that she was probably the brains behind this operation. And it was more of like a hidden figure situation. So Dr. Gibbon in the 1930s developed this unit right here. And this was one of the first cardiopulmonary bypass units, which is now known as ECMO, you know, further advancements of this machine. In the 1930s to the 1950s, he did experiments on cats to see if this would actually work. And then in the 1950s, he actually did the first open heart repair in atrial septal defect in an 18-year-old pediatric, well, borderline pediatric adult child, which went successfully. So looking at this ECMO unit, how much did you guys guess this weighed in kilograms? Who said it? 1,000 kilograms. So this thing weighed 1,000 kilograms. It was about the size of a piano. Compare and contrast that to what we use now when we look at like our cardio help and those types of circuits. So in the 1970s, Dr. Kolobau developed the oxygenator, the membrane lung, which is now our oxygenator. And initially it was just an envelope that was wound around like a plastic spoon. And again, that's undergone a lot of revisions to what we have today. Does anyone know who this gentleman is? Yes, yes. So, taking clues. So this is Dr. Bartlett. He is from Michigan. He's a pediatric surgeon, and he's coined the modern godfather of ECMO. I've had the opportunity, the privilege to meet him at a couple different ECMO conferences and workshops. He's a very nice man, but he is one of those people, one of those physicians that drove ECMO forward even when the evidence wasn't there. And one of the main reasons why ECMO is still in play and available for us to use for our patients. So in 1972, VV ECMO was first successfully done on adult patients with post-traumatic respiratory failure. And then 4 years later, Dr. Bartlett did the first use of ECMO in neonates with ARDS. So some things to note about ECMO is this was a surgery thing. medicine doctors were not initially the people doing ECMO. So most of the experiments and the developments of ECMO were surgery. So even when I was interviewing today, a lot of the candidates were saying, you know, it's so impressive that the medical intensivists are actually managing ECMO patients at Henry Ford, because this is not something that happens everywhere. You'll often encounter anesthesiologists or surgeons that take this on. But again, it's adaptive, because these are our patients that end up requiring it when we're talking about VV ECMO for ARDS. Initially, it was used in the OR setting. And that's because these patients didn't do well. They had long-term complications when ECMO was continued outside of the OR. So it was primarily an OR thing, cardiopulmonary bypass, and not continued afterwards. And then most of the widely accepted literature was in the pediatric population. So when you're talking about peds versus adults, ECMO for peds is a slam dunk. They do it. There's evidence for it. It's a little bit different, and we're going to talk about the evidence for adults. But for pediatrics, it's very well validated. And then if you're ever looking into the history of ECMO and you look back before the 1950s, you may see more so ECLS, because ECMO wasn't coined to the 1950s when the membrane oxygenator was used. And that's when you'll see it used more continuously in the literature. So between the 1950s, 1990s, early 2000s, ECMO had a lot of advances. One of the main ones was anticoagulation. Thrombosis was a main complication following ECMO placement in the OR. Once we started systemically anticoagulating our patients, they started doing better, of course, having less circuit thrombosis and less thrombosis in the patient. This led to prolonged use and improved survival. The other thing was that when an ECMO was initially started, we were using it only on patients that were actively dying. And we realized that is not where you can have the best effect. So when we started implementing this and we had more experience with ECMO, our survival improved. Also, we had a more structured approach to these patients. How many of you guys have heard of ELSO? So ELSO Extracorporeal Life Support Organization is the largest ECMO organization. It's all over the world and has grown tremendously over the past decade. And what this does is it emphasizes a couple things. It develops guidelines, so we all have a standardized way we approach these patients. It generates original research and publications, and it keeps the largest database that we have of ECMO patients to date. So what's the evidence? There are 4 randomized controlled trials for VV, well, landmark randomized controlled trials for VV ECMO and ARDS, only 4. There's a lot of observational studies and there's a lot of case series, actually very large case series, but these are the 4 landmark trials that we're going to briefly go through. So the first one was an NIH funded trial by Dr. Zapol in 1979, and it was 90 patients. They were randomized with ARDS. They either got VA ECMO or they got standard therapy for ARDS at the time, and it was a poor survival, 10%. Only 4 patients out of each group lived. And the conclusion they drew from this trial was that ECMO can support gas exchange, but it doesn't increase long-term survival in patients, so it shouldn't be used. There's no advantage to it. So there was kind of a lull in ECMO use after that. People said there's no advantage. I mean, this was a randomized controlled trial, even though it was 90 patients. Until Dr. Morris came in 1994, and he conducted another randomized controlled trial looking at a slightly different aspect of ECMO. So you know you can use ECMO for oxygenation, but he actually looked at it for CO2 removal in refractory hypercarbic patients. And again, he had 43 patients, and he randomized them to either CO2 removal or standard of care. And ECMO was actually effective at removing CO2, but there was no difference ultimately in the outcomes, which are looking at mortality. So after that, there was actually a downslope in the use of ECMO. Between the 1990s and the early 2000s, which we'll talk about, ECMO use was not a popular thing. It was not a popular management modality. But when we look back at these trials now from this vantage point, the patients in these trials were very sick. They had high disease illness severity. The centers that were enrolled in these trials, they didn't have any experience. So you started putting patients on ECMO with physicians that weren't used to managing ECMO patients. They put a VA cannulation in every single patient. So what type of do we use VA or VV ECMO for our patients in the ARDS? VV. Does anyone know why? I'm sorry? Yeah, the heart's working, you're correct, yes. I guess, so additionally, maybe, and I guess what I'm asking, but additionally, the VA cannulation comes with a lot more risk, right? So when you're cannulating the artery, you have risk of pseudoaneurysm, you have risk of dissection, the risk of hemorrhage is a lot higher. So that's why, in addition to not needing the cardiac support, why we choose the VV configuration. In the Zapol trial, it was noted that these patients on average required 4 blood transfusions, which was higher than was documented anywhere else. And again, was that a result of the cannulation? That's what some people theorize. And then no one was doing any lung protective strategies at this time, just based on the time period that this occurred. Yeah.
Is 10% survival Is that in both groups? Was it equal?
Correct, yes. So only 4 people survived in each group.
So survival wasn't worse.
It wasn't worse, no. Glass half full? Yeah. And so this is probably the trial that most of us are familiar with, right? So this is a CESAR trial, and people who are for ECMO are like, CESAR trial, you know, this is it. So this was a randomized trial, and this was in 2009. So patients were randomized to standard treatment center or randomized to transfer to a regional ECMO center. So it's important to note they weren't randomized to ECMO, they're randomized to transfer to a regional ECMO center. In this trial, you can highlight they used VV ECMO cannulation on all of the patients that were here, and there was a significant survival benefit in patients transferred to an ECMO center. Something to make note of is that 17 of these patients that were transferred to the ECMO regional center never got ECMO. So people take different things from this. Some people say this shows that ECMO has a benefit in patients with severe ARDS, and other people, which I think is the appropriate conclusion to be drawn, are patients do better when they're transferred to an ECMO center when they have severe ARDS. But the thing is, this CESAR trial gave a little bit of hope to ECMO believers, and this happened just before the H1N1 influenza pandemic. So I mean, we're going through a pandemic, right? So when you have a patient that has severe ARDS and they're a young, healthy patient, and you have them on high vent settings, you have nothing else to offer them, this offered some hope in another modality. And that's why during this pandemic and combined with the CESAR trial results, people started using ECMO, and there was a huge surge in ECMO usage in 2009. So you can see here, basically where this red line is, you just see an upward trend. This is the number of centers that used ECMO, and these are the number of runs that were being done. And again, this was a combination of what was happening at the time with the pandemic, as well as maybe some positivity from that CESAR trial.
In the protocol analysis, when they looked at the patients who actually got VV ECMO versus not, was there still the benefit was still maintained, or was it dissipate once they?
Say that one more time.
So when they looked at the patients who actually got VV ECMO, and if they were transferred to that center versus the patients who didn't get VV ECMO, was the benefit still evident, or was it just the transfer that they?
No, it was just the transfer. Yeah. So there was no statistical significant difference in mortality just with ECMO versus patients that remain at the other facility. Does that answer your question? Yeah. Okay. So because people started using this more, what happens if you start using a modality, whether the evidence was necessarily slam dunk or not, money started kind of pouring in for ECMO research, for advancement of ECMO circuits and things like that. So what we started seeing is the change in vascular access techniques. So historically, to put in an ECMO catheter, you do a surgical cut down. So you cut the skin, you cut the vessel, and you put in the cannula. After this, when people started using it more, we developed more sophisticated techniques of like percutaneous cannula placement, like similar to a central line. That's how you can put them in now. The cannulas were smaller. We had dual lumen cannulas or catheters. So you only needed one site, which decreased risk of infection and risk of complication. And then they started becoming heparin coated, so they're not as thrombogenic. We had heparin coated circuits that came on the scene, smaller circuits compared to what I showed you with Dr. Gibbon. Now we have the cardio help we use, which is much smaller. And then our oxygenators just became more sophisticated and efficient and lasted longer, so you didn't have to switch them out as much. So how many of you all have heard of the Olio trial? Yeah, I read this one from a couple years ago. So this is the last randomized control trial that we're going to talk about, the most recent one. They looked at 250 patients, very severe ARDS, compared to an ECMO group, ARDS randomized to an ECMO group or to a control group. And primary endpoint mortality, 60-day mortality was what they looked at, and it was not significantly lower in the ECMO group. One thing to note about the Eolia trial was that if your patient was in the control group and they were doing really badly, and you were on max settings, they had high plateau pressures, the physician had the ability to cross them over into the ECMO group. So what ended up happening is that 17 of the patients ended up crossing into the ECMO group. And this just happened to be the patients that had the worst ARDS based on their P to F ratio. So there was a trend to lower mortality, 35% in ECMO compared to 46% in the control group, but it didn't reach statistical significance. Some of the secondary outcomes did favor early VV ECMO in these patients, lower number of days prone, some lower organ dysfunction, but overall the 6-day mortality showed no difference. So worth noting is what I just said. There was that crossover, 35 patients. I said 17, that was from the other trial. 35 patients, so 28% the control group ended up crossing over. And what the concern is that may have diluted the sample, the ECMO sample, which could have given us results that we can't necessarily draw that conclusion from. Like, could we have reached statistical significance? Because this study was stopped early at the interim analysis because there was no difference between those two groups. And just to note, this is one of the issues with a randomized controlled trial in ECMO, right? Because it's become so infused in our culture and some people consider it the standard of care, that to tell a physician that they cannot offer ECMO to somebody that has severe ARDS creates a problem. So we think that there's a lack of equipoise, and that's why it will be very difficult to conduct a trial like this today. So based on that literature, some people drew from it that ECMO is worth trying, especially in those patients that have severe ARDS. Other people, again, are kind of in that undifferentiated category. But when you add the evidence to the ECMO physiology, I think that's where I personally really get sold. Because the evidence, as we stated, is not overwhelming, but I think it shows some potential benefit of the modality. So we're talking about ECMO physiology. We know that ECMO is in place. We talked about VA and VV. It's for heart and lung support when your patient has severe injury, and the conventional methods that we use to care for this patient aren't there. When we have someone with heart failure, some of the modalities we put in, some of the devices, some of the ionotropes, they actually can create damage, right? Those medications, in addition to vasopressors. When we have someone on high ventilatory settings, we know that that can create short-term and long-term damage for these patients. So the goal of it is to put this patient on this treatment, give them a rest, give those lungs and organs a time to recover, give them a time to be treated if it's an infectious reversible process, or to be transplanted. So when we're talking about cardiopulmonary physiology, you have to understand, of course, the delivery as well as the consumption of oxygen and what's happening. So when you're talking about metabolism, it's related to O2 consumption, and we measure O2 consumption by our VO2, it's the oxygen consumed per minute. So how many people in this room, how many of you all work out on a regular basis? I ask this during rounds all the time, but how many people work out regularly? Raise your hand, be proud, raise your hands high.
Blaming COVID.
Okay, excuses. So a few of you do. And when you work out, what's happening with your metabolism? It goes up, right? And then as a result of your metabolism going up, your delivery of oxygen goes up, right? That's how you compensate for that. So your normal delivery of oxygen is about 5 times the amount that you actually need. So DO2 is about 5 times of your VO2. And that's to account for things like this. That's so when you work out, all of a sudden, you don't go into shock, right? That's so when you develop a fever or, a mild infection, your body's able to compensate. So those are some of the things that increase your delivery of oxygen. Some of the things that decrease your metabolism and subsequently decrease your delivery of oxygen are things like hypothermia protocol, sleeping, why we paralyze some of our patients that are dysynchronous with the vent. So when we're talking about the delivery of oxygen, you have to mention oxygen content, right? The oxygen content in blood. And this is important. I use this formula every time I'm in the ICU, literally with every patient that I'm evaluating, that I think that there's a delivery of oxygen, consumption of oxygen mismatch, which is pretty frequent. Also, it is going to be tested on your board. So who can tell me the oxygen content formula, or what the components of it are, even if you don't remember the specific numbers? Good. Good. So yeah, you mentioned the key point. So hemoglobin times 1.34 times saturation, and then this last part ends up being, in most cases, like negligible. So we don't really consider this in part of the equation. So do you guys know what affects your oxygen content more, hemoglobin or oxygen saturation? So hemoglobin does. They both do, but hemoglobin does to a higher extent. So if you look over here, what's your normal oxygen content in your blood? Oxygen content in cc's per deciliter. It's going to be good. So it's going to be 20 ml. So if you take somebody that's a hemoglobin of 15, their oxygen content with a saturation of 100, the oxygen content is going to be around 20. You can see that as you decrease that hemoglobin from 15 to 10, what happens to oxygen content? Goes down to 15. And if you half it, your hemoglobin is going to half your oxygen content, right? So if you look at your, so let's say, let's go here. So hemoglobin of 7.5 correlates with the oxygen content of 10 cc's per deciliter. To get to an oxygen content of 10 cc's per deciliter with a hemoglobin of 15, your saturation has to be where? All the way down to 75%, right? So you have to have a pretty major drop in your saturation, even though it does contribute to the overall oxygen content of the blood. When we're talking about oxygen delivery to your question?
Oh, no, sorry.
Oh, okay. When you're talking about oxygen delivery to metabolizing tissue, all you're doing is adding on the cardiac output, right? Cardiac output, heart rate times stroke volume, and then your stroke volume is made up of preload, afterload, and your contractility. And that altogether comprises your delivery of oxygen to your metabolizing tissue. So DO2 cardiac output times oxygen content, your oxygen content we went through, and your cardiac output, again, heart rate times stroke volume. So how does that kind of fit into the whole picture of ECMO? So as we stated before, you are generally living here. Your DO2 is 5 times the amount of your VO2, your oxygen consumption. So this is where we live in a normal state. If you become hypermetabolic for any of the reasons we mentioned, what's gonna happen? Your DO2 is gonna pick up to about here, and to maintain that ratio, because it can do that for as long of a period as it can, as long as your oxygen consumption is within a certain range. And when you do that, the deoxygenated blood returning to the right side of your heart will be around 80%. So what happens if that metabolic keeps going higher and higher and higher? You get to a point where your heart, your delivery of oxygen cannot compensate as much. So your ratios will slowly start to decrease. And with that, you see that decrease in that deoxygenated, the oxygen in the blood that's coming back to the right side of your heart. So when ECMO, most of the guidelines with ECMO address the point when you get to around 2 to 1. And because when you get to around 2 to 1, that's when you start to undergo anaerobic metabolism. You start developing lactic acidosis. That's when you start to have signs of end organ injury, and you start having circulatory collapse and shock. So what we want to do is we want to address that oxygen equation, that delivery of oxygen before we get to this point. And that's where ECMO comes in, because we can address the oxygen saturation and the oxygen content equation prior to getting there. That's how ECMO directly affects the delivery of oxygen. How it indirectly affects the oxygen delivery is, we talked about when you get to that 2 to 1 ratio, you have end organ damage. That end organ damage includes cardiac damage. So you can actually have cardiac suppression that often occurs when you have someone who has bad sepsis, fulminant sepsis at this point. So if you can intervene in terms of their oxygen delivery earlier on, again, it can also indirectly affect their delivery of oxygen. Any questions about this? Okay, so when do we consider ECMO? Again, I mentioned some guidelines say when the DO2 to VO2 is a ratio of 2 to 1, but we're not usually calculating that on a regular basis in the ICU, but you can get an idea of that based on what you're seeing. So if you have severe hypoxemia that's not responding to maximum conventional vent management, that's a reason to consider ECMO. If you have a good oxygenation, but to get there, you know you're creating damage to the pulmonary system. If you have high plateau pressures, high PEEP, you're not able to maintain those low tidal volumes, then that's a reason for ECMO, even if your patient's satting 95%. Also, if you have persistent hypercarbia and you know you're having to increase those tidal volumes higher than what they should be for lung protective strategies, again, that's a reason to put a patient on ECMO. So to put a patient on ECMO, you have to understand the components of ECMO. And you have to understand what they do in a normal setting. You have to understand what they do in an abnormal setting, or when there's complications. So the ECMO circuit can look very differently. It can look like this, compact, like the cardio help, or it can be completely separated out, right? Where you have the pump down here, oxygenator here. So the pump is pumping this darker deoxygenated blood here, and the oxygenated blood is coming out back to the patient. The important thing is to first get a bird's eye view of the system, so to understand the flow of the blood, and then to kind of break it down into individual parts. So the drainage cannula, also called the inflow cannula, and then the return cannula, also called the outflow cannula. The inflow and outflow are in relation to the ECMO circuit, so when you use those terms. So inflow drainage cannula goes directly to the pump. The pump pumps that deoxygenated blood to the oxygenator, which oxygenates the blood, and then that oxygenated blood goes to the outflow cannula back to the patient, or the return cannula. When you have the patient and you're thinking about them in regards to the system, it's a very similar thing. This is a catheter, it's a dual lumen catheter, so it's 2 lumens inside this single cannula. And what happens is that deoxygenated blood goes to the pump, again, Deoxygenated blood is pumped to the oxygenator, and oxygenator, following that, oxygenated blood goes back to the patient. This is the gas blender. The gas blender is attached to the oxygenator, and that's where the flow of gas comes from, so that gas exchange can actually happen in the oxygenator. The console is where all of our measurements take place when you put the patient on ECMO, and that's how we can have a gauge of what's going on, and that's how we can titrate flow and other things that we're going to talk about. So some things about the VV circuit before we talk about the specific parts. Everyone always asks me, you know, what settings do I put my patient on when my patient's on ECMO? And there are some settings we're going to talk about, but what you have to understand is each person is individualized. So like we talked about the DO2, VO2, everyone you put on ECMO isn't going to be at the same ratio. Everyone isn't going to have the same metabolic state. So you have to titrate to the patient. We'll talk about how to do that because each of your patient's needs are going to be unique. For VV ECMO, I think Assam mentioned earlier that hemodynamics are not affected by VV ECMO. If you're having a hemodynamic issue, specifically cardiac, then you may want to consider a different type of ECMO. Volume of blood infused is the same amount that you're going to get, volume of blood removed rather is the same amount that's going to be reinfused because a closed circuit, you're not losing any blood in this process. And then we're looking at the oxygen content as well as the carbon dioxide content. It's reflective of the ECMO circuit, but also your native lungs can still have some function. So they're also participating in the gas exchange to different extents based on your patient's underlying pathophysiology. So we're going to walk through one more schematic first before we talk about the individual parts. Left side of the heart sends oxygenated blood to your tissues. So you have your consumption of oxygen here in your tissues, and then you have your total venous return of deoxygenated blood back to your heart. One thing to remember is important about ECMO is that all the blood doesn't go through the ECMO circuit to be oxygenated. There's some blood that bypasses the ECMO circuit and goes directly back to the right heart. And that's why you'll see in the ELSO guidelines and the ECMO guidelines, which we take for our ideal SAT, it's going to say 80% is kind of the lower end of what you want. And again, that's one of those things that's titratable per patient, but we don't aim for a 95 to 100%. It's not realistic to have in these types of patients. So the parameters we're going to go over affect oxygen delivery, carbon dioxide removal, and the flow of blood. And we're going to talk about cannula size, sweep, flow rate, as well as inflow pressures, because these are the things you're going to look at on those console. So what equation is this? Who remembers it? I'm going to butcher it. What'd you say? Let me hear the French accent. Pucelles. Yes, that's it. So who can describe this to me?
So flow is given by change in pressure divided by resistance.
Good.
Resistance is actually given by viscosity times radius to the fourth power. Sorry. Yeah. No, sorry, radius to the fourth power divided by viscosity times the length.
Good.
When the radius goes to the numerator, it becomes change in pressure times radius to the fourth power divided by viscosity times length.
Good. So basically what you were saying is that resistance and length is inversely related to flow, and the radius is directly related to flow. So in layman's terms, the shortest, fattest catheters are going to have the highest flow, similar to when we're transfusing somebody who has blood products. So another thing to note when we're choosing cannula size is the size of your patient, right? So there's different French catheters, and we'll talk a little bit about the catheters. If your patient is a larger patient, they're going to require more flow. So you want to opt for a cannula that's larger that can give you more flow through that cannula to that patient. And oftentimes, if your patient is large enough and requires more flow, they may need the addition of an additional inflow cannula. So it's an additional drainage cannula to take more blood to go to the ECMO machine to be oxygenated. So there's different configurations of ECMO as we've seen. So there's two cannulas, we said. Those two cannulas can be both in the fem veins. There can be one in the fem, one in the IJ. This is the most common. Or there can be one in the IJ that has two lumens going through it. Based on whichever configuration you pick, it can have an effect on how much flow you can have through the ECMO circuit. So you can see that the fem jugular and the fem end up having, this is gauged a little bit low, but end up having higher flows than the dual lumen just because you can get to larger sizes. The dual lumen most of the time has a restriction on flow, but it can still get up to 4 to 5 liters. The other thing to note is just the price. We use the dual lumen inflow because it allows your patient to be mobile. It allows you, it's more comfort. They usually require less sedation, but it is a more expensive modality to have that cannula in place. So how you put this all in context, if you have a very large patient that you may be worried about achieving big flows, so a very obese gentleman, and you won't know he may need a flow between 5 or 6 just based on his body habit, this may be somebody you're considering a FEM to IJ approach as opposed to just the dual lumen catheter. So typical flow, and these are a little bit underestimated, but typical flow. So configuration here would be, anyone describe it for me? Good. Good. Yeah, so these two here are going to end up having the higher flows, which again will go, this says about 3 to 5, and the dual lumen will have a little bit lower, 3 to 4.5, but again, there's some give and take with those numbers. The sweep is the gas flow that we talked about. So you have the air blender that delivers gas to the oxygenator, which provides for the exchange. Sweep is what clears CO2. So sweep is going to clear CO2 more than your flow. So a lot of times someone's not oxygenating well, you'll go up on the flow. If you go up on the flow, it's not going to have as much effect on the CO2. Because CO2 diffuses more rapidly than O2, to really have changes, you need to increase the sweep. And you want to adjust the sweep to actually keep the PCO2 within normal limits. And the sweep, even though you can go to 100% FiO2, it generally does not affect the oxygenation for the patient. And again, flow kind of piggybacking on what the cannula conversation was, ideally what you want to do initially is adjust that flow to 4 to 5. Like, as I said, there's no specific settings that you have for every patient, but you go to 4 to 5. The next step is to get your patient to rest settings on the ventilator. Once you get there, then you can adjust the flow to the lowest flow that will compensate for that patient's metabolism. So generally you go to 4 to 5, you go to rest settings, and then you can titrate down the flow as long as you're meeting your appropriate endpoints. And you adjust to meet your patient's metabolic demands. The inflow pressure is the last component we're going to talk about. So you have a negative pressure on the inflow cannula. That's what draws the blood in. The normal negative pressures are between -50 to -80 millimeters of mercury. If you are going more negative, so if you're going above -100 millimeters of mercury, it can suggest that you're working too hard to pull that blood into the ECMO circuit. So there's impaired drainage for whatever reason. We care about impaired drainage or that high negative pressure because it can lead to hemolysis, it can lead to low flows, you can have chugging. Now that being said, there was a patient we had on ECMO a couple weeks ago that their negative pressures were in the 150s, but that's where they started. There was no change from when the initial cannula was done. The patient was perfusing appropriately, there's no lactate, and so not many changes needed to be made. But this is something that if you have a patient that starts out at a negative pressure of 80, you're diuresing, then all of a sudden they're a negative pressure of 100 or 120, you're concerned that maybe they're hypovolemic. Maybe I took off too much fluid. Or is my cannula in the right place, or did it change it from the appropriate position? Is there a blood clot? You're examining the line, or is the tube kinked, which again, that's a pretty obvious finding, so it happens a little bit less frequently. Okay, so the last thing we're going to do is we're going to work through a case. And this is actually a case that the ECMO care team saw. So we're going to do some direct clinical application of these things and hopefully answer some questions along the way. All right, someone want to read the case for me? Anyone?
Ms. Jones, a 33-year-old female, 55 kilograms, past medical history of asthma, transferred from outside hospital for PV ECMO evaluation. Recently been diagnosed with multifocal pneumonia, flu A, and ARDS. Presented to Hurley, 228, transferred to Henry Ford the same day. Hurley patient was intubated, had a lactate of 4, then BCs of 1, B1 66, creatinine of 3, INR of 1.3, trope of 0.61 with normal liver profile and neuro function. Paralyzed prior to transfer on nitrous oxide without improvement. So was saturating 80% on arrival, hemodynamically stable, with original settings of 100% FiO2, P26 with plateaus at 38. Tidal volumes of 6 cc's per kilogram, PDF ratio of 51. ABG of 6.96, PCO2 103, PaO2 51, and bicarb was initiated.
Okay, so again, this is a true story. a true patient experience. For the first years, you have this patient. Yeah, I'll gear this towards first years. You have this patient. What would you do? Collect both, okay. I think that's a fair and safe response. And actually, it's a great response, right? Because one of the things I mentioned historically was that they were starting ECMO too late, right? When patients were too far down the line. So one of the things that we want to educate you all on is that you see this patient, you're calling the ECMO care team. Whether they're cannulated right then or not, they should be called to at least do a evaluation, decide if the patient's a candidate. What else are you able to do? Okay, you can come down to tidal volume. You want to come down to 4, all right? Ultra protective. I like your ultra protective vent settings. Yeah, so the thing here, we don't offer, unless you're in pod 4 with pulmonary hypertension, we don't use nitric oxide here for our ARDS patients. And I know when we're talking about camps, there's camps for that as well. But yes, I mean, another institution, you may be able to offer that. Yeah, so you prono, right? So you call ECT. I saw Nor doing a flipping motion over there in the corner this whole time. Yeah. But yeah, so you can do all those things you mentioned. I think those are all good suggestions. And then you want to prone the patient, right? So you prone the patient 16 hours and then you repeat the ABG. There's no change. So this is your patient. You're on overnight. You have to decide, am I going to wake up Dr. Gardner Gray at 2 a.m. or not? So is this a good patient for ECMO?
Yes.
Why? Oh, okay.
So we want to go back, like, go and look at what the indications are, contraindications are, what worked in the CESAR trial, you know, and all of those things. So like here, PF ratio obviously qualifies. So you do the Murray score basically to see how severe it is. In which includes, you know, you do your, has your PF score has, you know, a number of, there are 4 parameters, chest X-ray, you know, where exactly the disease is and all that. And then you also have to look at, like, why would, you got to look at the relative contraindications here.
Good.
So, you know, patient has renal failure, right? So that would, some would consider it to be a relative contraindication. So you got to weigh the risks and benefits.
I completely agree. I love that answer. I think it encompasses a lot of things that we're going to talk about. So this is what we pull up as the ECMO care team when we're doing an evaluation. And this is, of course, a consideration of the whole clinical picture, but these are some of the objective things that you can look at yourself. And this is a dot phrase, dot ECMO assessment, right? So as you mentioned appropriately, there's some things that the patient has to have. So do they have a high mortality risk? And that's based on, we often look at the P to F ratio, but there's some scoring systems. So Murray score, oxygenation index, APSS score, which we'll talk about. And then the length of time the patient's on mechanical ventilation. If somebody's been on the vent for 14 days or 20 days and the damage has already been done, ECMO doesn't provide a whole lot of benefit in those types of scenarios, right? Because we're trying to prevent that lung damage that the ventilator provides. The only absolute contraindication to ECMO is if this patient has a terminal illness. If they have 2 weeks, 2 months to live, it's generally not someone you're putting on, or if they have an anoxic brain injury, you don't know their underlying status. And that's for various reasons, including the risk of bleed if somebody has large ischemic strokes and you're starting them anticoagulation. But then there's a lot of relative contraindications that you touched on. So some of them prolonged downtime, but you're not sure if they have a anoxic brain injury. It's a question. 1 or more chronic organ dysfunction. Acute renal injury, you know it's generally not one that's going to keep us from putting a patient on ECMO within itself, because we know that 25% of patients put on ECMO end up developing acute renal injury anyway. If they can't take anticoagulation, if they have severe pre-existing conditions, compliance limitations, like cognitive or psychosocial limitations. We talked about the duration. If they're very old, and again, these are all relative, but extremely obese, we know that's associated with higher risk of infection, more risk of bleeding, or if it's futility. With the patients on 140 of levo with multi-organ failure, this is not somebody that we're going to pick for an ECMO candidate. So you mentioned the scoring system, and we can use P-to-F ratios, but some of the other scoring systems we use have been validated in ECMO. So I was having a discussion about oxygenation index actually earlier this week, because most of the literature is in pediatrics, but it is part of the scoring system that has been applied in an age-adjusted way to adult ECMO patients. But it looks at mean airway pressure and basically uses the cutoff here. It says 40, also uses 60 for ECMO, and that's what we use in our ECMO assessment note. So is the oxygenation index greater than 60? Then you have the Murray score, which is incorporates P to F ratio, but also looks at the amount of lung that's involved based on radiograph in terms of consolidation, as well as the PEEP that they're on and lung compliance. And then the APPS score, which is age, P is for P to F, and then plateau pressure. That's another scoring system you can look at. And again, it's all in that ECMO assessment note. So you can do a preliminary examination of these patients to determine whether or not they would be an appropriate candidate. So in terms of the, let's say we deem this lady to be an appropriate candidate. She's somebody, I don't know if you noticed, but she's 55 kilograms. So in terms of a configuration, when you call CT surgery, what type of cannula would you recommend, or would you think she would do okay with? Any. So if they do okay with any, what would you pick, Nora? Dual lumen, right? So we talked about dual lumen. If you have to prone somebody, you want a dual lumen. You want to prone them with like a FEM or a FEM-IJ. It gets them up. They have less sedation. It's just more comfortable. So if you can, then you could be opt for the dual lumen in someone who's young, otherwise healthy, and 55 kilograms. But from an anatomical positioning of the cannulas, just so you know, there's some other reasons why we picked the dual lumen. So Bifem catheters, here's the inflow catheter. So it goes into, both go into the IVC. Here's the inflow catheter here, just distal to the hepatic vein. And the outflow catheter, the reinjection catheter, goes right up a little bit higher into the RA. The Bifem configuration, the issue with it is the high risk of recirculation. Recirculation, anyone know what that is?
The outflow, sorry. So the inflow, basically, blood can go into the, so the outflow cannula blood can basically go and get recirculated into the inflow cannula.
Correct. So this cannula is taking in oxygenated blood. So if you have a flow of 3 through your ECMO circuit, and you're getting 0.5 liters of already oxygenated blood, you're not as efficient in terms of your ECMO, right? Because you want all 3 liters of that blood that's going through ECMO to be deoxygenated, converted to oxygenated. But here's how the bifemoral configuration has the highest incidence. No, but it can happen with a couple different, it can happen with Bifem, it can happen with FEM-IJ. And it can actually even happen with the dual lumen, but it doesn't, it happens rarely with the dual lumen and most with the FEM-FEM. I'll show you a picture of how it can happen with the FEM-IJ in a second. So here's the FEM-FEM. This is how we'll look on x-ray, because we're checking our x-rays every day on our cannulas with these patients. So the femoral jugular configuration, the drainage cannula, this is the most common. You can have it the flipped way, but this is the most common way to have it. But again, the inflow is just distal to the hepatic vein, and then the outflow from the circuit, again, is in the RA. And normally says how we'll look on x-ray. You see the distance between the femoral catheter and the IJ catheter. And we'll have a picture later. So I'll show you where you can see how recirculation can happen if that changes. And then the bicable single lumen, which we put in our patient. So this is a single lumen, but you see it has 2 sides. So one side acts as the inflow to the ECMO, other is the outflow. And then it only has 1 jet that's directed right at the tricuspid valve into the right heart. So this is actually more efficient way of getting that oxygenated blood directly to the right heart into the lungs, and then in left heart in circulation. And this is how the bicable will appear. So you see it goes all the way down through the SVC, through the RA into the IVC. All right, so John, you want to continue?
Following VV ECMO placement with a bicable cannula, the patient is doing well, can meet her ventilator to P10, respiratory rate 10, her volumes of 4 cc kilogram, FiO2 of 40. ECMO settings were FiO2 of 100 with a sweep of 5, circuit flow of 4, and repeat ABG showing 7.4, 40, 70, and bicarpal within normal limits.
Okay, who's happy with this? Or who wants to change something? Dan's happy. You're not happy?
Yeah.
Okay, you're happy. Nora's happy.
I wanted to set the peep on the vent settings. So I want to come down more.
You'll drop it a little bit lower. Yeah. And the rest settings, so if you go to any also course, well, not any, some of them will say 10 PEEP, 10 respiratory rate. There's no studies done to show what the ideal rest settings are for a patient. So if you want to go a little bit lower, no one will fault you. Sorry, what's that? Okay, so it's a little bit high. So you think we could probably come down on the flow a little bit for this patient? So the FiO2 on the circuit doesn't affect the oxygenation as much. So when we're talking about the FiO2, or when we're talking about the oxygenation, flow is going to affect the oxygenation, and then sweep gas flows are going to affect the CO2. But I agree with you. I think we could probably come down on the flow with this patient. That may be a change that we can make. Anything else? Everyone else pretty happy? Reedy's very particular, but okay. So everyone else is pretty happy. So I'm happy with that. But I do think that's a good point to titrate the flow down. You want to go as low as you can while supplying the metabolic needs, as I stated. So 24 hours later, you're called frantically by the perfusionist because Miss Jones desaturated to 70 while they were giving her a bath. So now what do you do? Second and third years. Okay, so chest X-ray. Okay, I love how you're getting the rest of the vitals. Good.
Check the circuits.
Okay, so in order of things, so I guess you're ordering the chest X-ray while you're headed to the bedside, and then what did you say on the bedside?
Check the circuit.
What was circuit? You run the circuit. Good. And what are you looking for when you're running the circuit, Nor?
If there's a kink, if there's any mark misplacement, there are usually indicators on the outside.
Exactly. Yep.
So if it's being changed, if the suture has been either fallen or if there's any change in that, color of the bolt, if it's chugging or there's nothing like any, what's the, you know the prior settings, 4 liters and 5 liters. Mm-hmm. Is it circulation still same or not?
Good.
Good.
Yeah. Good. Hey, that's good. I appreciate that. Going to the bedside first, doing a circuit check is absolutely important. Everything that you mentioned. What else? What's okay? Okay, good. The patient's setting 70%. So while you're doing the rest of this, you may, if you can, and sometimes you can't. You know, it depends on how bad their pulmonary function is. But maybe you go up on the vent settings temporarily to help you. Oftentimes, if you can avoid going back up on the vent, you try to fix it with the ECMO circuit. But there have been times where that's the last resort. But I wouldn't do that as my reflex. So just so you know, I wouldn't go up on the vent. If you can change it with the ECMO, try that first. What else?
The console, see if there's any change in the SVO2 or anything.
Good. The SVO2 change. Maybe the venous pressure we talked about, did that change? And as Nor mentioned, flows. Good. So first, oh, what'd you say, Nor?
I mean, he was most likely it's a malposition on, right? Because the patient was being turned.
Yeah, yeah.
So the X-ray.
Yeah. I'm sorry? Did you say call who? Call the don't call me. No, I'm just joking. Call me. But yeah, so Nora brings up an excellent point, the going to the bedside and doing the circuit checks. And considering that you can have cannulas dislodge and move in all types of patients, but the cannula that's most sensitive to any type of movement is going to be this dual lumen single catheter. And the reason being this, right? This has that one jet that's pointed towards the right side of the heart. So any change or dislodgement in this catheter could completely change your oxygenation situation. Compare and contrast that to some of the others. If this gets pulled a little bit this way, that gets pulled a little bit that way. I mean, you may see some subtle changes, but you can see big changes, especially when somebody has that single lumen, dual lumen single cannula. But you have this, to create an overall picture, you have a hypoxic patient on ECMO with ARDS. So I think you all mentioned great things. Develop an algorithm in your mind and how to address this though, because it can be as easy as going through a checkbox. So how I look at this is I'm like, is it my patient? Kind of like with a vent, right? Is it my patient or is it the machine? Is it the ECMO circuit? So for your patient, are they bleeding, right? We talked about oxygen content. There's a reason why we went through oxygen content, oxygen delivery. Hemoglobin has a huge effect on that. Are they bleeding from somewhere? Are they hemolyzing? Are they in DIC? Cardiac function, all of a sudden do I have cardiac failure? Cardiac is part of that DO2, right? The cardiac output. Preload, afterload contractility, part of that stroke volume. Is there increase in pulmonary shunting? In my ECMO unit, do I have recirculation, which we talked about? Is it an oxygenator issue? Somebody mentioned with clots. Or is it ECMO flow that captures less than 60 to 70% of my cardiac output? Or is there an issue with my cannulas, which we talked about? So I'm going to kind of shoot through these things pretty quickly because we're running close on time. But I have a special picture I wanted the interpretation of the side of the room for. So I'll make sure that I get to that slide so you guys can take a look at it. So when we're talking about anemia, we said bleeding hemolysis DIC. So there's no transfusion threshold in ECMO patients. It also actually says keep them 12 to 14. There's only been small studies that actually show that there's no real benefit to that, but they're very small. So what the general guideline is keep the patient at their baseline. So if someone lives at a hemoglobin of 10 and they're at 8 and you have signs of a DO2 to VO2 mismatch, get them back up to their 10, okay, if they're hypoxic. Recirculation, we talked about that. So it can be a cannula position issue more often than not. And what well, I'll go here. So this is the IJ-FEM configuration, as Hafsa was asking earlier. So generally you have about 15 centimeters between the inflow and outflow cannula. If you get an x-ray and you see the tips of the cannula and they're that close together, that is something that's going to be on the highest differential. The other thing you can see on recirculation is that you lose the color differentiation in the cannulas. So deoxygenated blood is generally darker, oxygenated blood is generally brighter. Look at the tubing when you do your circuit check. If they're the same color, that's another reason that should come to mind. We went over that. And recirculation is highest in FEM jugular can be present, dual lumen is the less likely. Cardiac function, is your cardiac now failing? RV failure is pretty prominent in patients that are on VV ECMO, and this number will go up with the amount of time they're on it. It's because they have microvascular thrombi, it's because they've had hypoxemia. All of these things can contribute. So you can also have de-recruitment once you go to rest settings. If you're reading your event very quickly and you have de-recruitment, again, that can have an effect on your cardiac function as well as your oxygenation. And a lot of these patients receive a lot of resuscitation in the acute phase. So a lot of times they're having pulmonary edema and things you're dealing with that when those peak decreases happen, again, it can cause some of this this de-recruitment. So these are things that your ECMO will, your X-ray rather, will help you delineate when you get it to check. You may need to increase settings, as Mike mentioned. Again, we oftentimes try to troubleshoot with the ECMO first, but the patient's hypoxia, you have to go up temporarily in the vent, then you do what you have to do. But ideally, you want to get those back down as soon as possible to achieve the overarching goal. Alveolar recruitment maneuver. So can you prone on ECMO? Yes. Do we have an official guideline on how to do that here? No, but that's something we're working on, particularly with that single cannula. You should be able to still prone these patients and recruit. All right, so this is the last thing. I think we'll probably end on this. So I saved this for you guys. Actually, it's for everyone. I'm not going to put you on the spot. So I'm going to give you, what did Jack call it? A waiting?
Time, yeah.
A wait time. So I want you guys to take a look at this. So this is figure A. I'm going to break it down a little bit. This is normal, and this is figure B. This is not normal. So if anybody can take a shot at what's happening in these two figures in relation to the ECMO circuit. Okay, so I hear some difference in the flow. So here, this is the cardiac output here, just to give you some context. Cardiac output here, and this is the cardiac output here.
So it's actually bypassing the ECMO, the oxygenator, right? There's more flow across.
Good.
So it's bypassing the oxygenator, probably because of that increased cardiac output.
Good.
We aren't able to have that appropriate suction from the venous blood and then reinfuse it as an oxygenated blood. So we're shunting through more deoxygenated blood into the circulation.
Absolutely. Excellent. So this is your normal patient, the 5 liters cardiac output, right? So it goes to the peripheral compartments and they extract oxygen. This is your SeVO2, that's that deoxygenated blood. With that deoxygenated blood, what our goal is with ECMO is to capture 60 to 70% of your cardiac output with the ECMO unit. That will provide enough oxygen to carry out your metabolic activities. So here you have 3.5, that's 70% going through the ECMO unit, getting oxygenated. But you see this 1.5 liters, this bypasses the ECMO circuit. it will still go to the lungs and may get oxygenated there, but we don't know. This is just considered deoxygenated blood. So this is usually okay. But what happens when your patient becomes septic that's on ECMO? You don't just, there's no light that flashes and says all of a sudden their cardiac output is 10 liters. What you'll see is you'll see a couple things happen. The patient will desaturate, and you'll probably see an increase in their CO2 because of their hypermetabolic state. So this person is hypermetabolic. Let's say they became septic on the unit. I'm still, my ECMO is still only set for 3.5 liters. So 3.5 liters is still being oxygenated. But look how much this deoxygenated blood is going through. It's all mixing in the right heart, but now I have this larger component of deoxygenated blood causing my patient to be hypoxic. So anytime I see an acute decrease, I go through these steps. If I get here, if the patient has any type of fever, maybe a slight increase in their white count, very low threshold for drawing blood cultures, for empirically starting antibiotics, for getting x-rays, look if there's any new type of consolidation, any new wounds or any type of new infection or something that can cause a hypermetabolic state to increase their cardiac output. And this is something that it can be recognized a little bit later on because you take too long going through those other steps. So I want to make sure that this is something that sticks in your mind that needs to be addressed on your patient on ECMO that becomes acutely hypoxic. Questions about this?
This can not just be in sepsis, this can be in anemia too, right?
Exactly. So it can happen in sepsis, it can happen in anemia, it can happen in anything, any type of high output failure, anything that that will increase your cardiac output, this can occur with. You just have to be cognizant of it. And generally we do the right thing. Reflexively, if we're hypoxic, we go up on the flow. But again, understanding the etiology and treating that is going to be important. All right, oxygenator issues. That's what clots look like. Of course, that's going to lead to hypoxia on your patient. How you determine if your oxygenator is failing and not working is you want to see what the blood looks like after the oxygenator, right? After the oxygenator, you should have oxygenated blood and the CO2 should be removed. If that's not happening, then there's a problem with your oxygenator. It needs to be addressed. There's pressures between the oxygenator. The pressure usually is less than 50 in the blood before and after the oxygenator. If that pressure starts to go up really high, there's some type of blockages happening. Most often it's some type of thrombosis. If it gets above 100, this is something that perfusionists can check for you. Say, can you give me an oxygenator evaluation? If it's above 100, you may need to consider exchange, especially if the gas exchange is not appropriately happening. And then if you go through all of those and everything's completely normal, that's when you say, okay, maybe my cannula size just wasn't right. Maybe I didn't assess this right for this patient and I need to put in a second drainage cannula, which means that I'm taking more liters of blood to my ECMO unit to be oxygenated and go back to the patient. All right, so that's basically it. Give you guys an overview. I don't know if you know, it was 15 patients overall. I added a few, I exaggerated. So 15 patients in 2019. We expect more for 2021. 2020 was a bust due to COVID, but we are making a lot of advances and really excited about the ECMO program. And we have a new fellow curriculum that's going to be discussed at the next meeting. So we're very excited about getting you guys on board too. All right, so VV is an option. Interpret your DO2, VO2 clinically if you're not calculating it, and make sure you have a very good understanding of the components. We don't see these patients regularly, so this is something you guys have to take upon yourself to review and read up on the complications and things like that, because that's the only way it's going to stick. All right, thank you guys. Sorry I went a little bit over. Yeah.
Is it still where if a patient's in our ICU, they go to ECMO, they go to P5, but we're still primary? Or?
Correct. We are primary for our patients now. And we are putting COVID patients on ECMO if they meet that criteria.
Okay. You are or you are not?
We are. Yes.
Sorry, I have just a couple of real quick questions.
Yeah,
Would
yeah.
you be able to tell if there's like any recirculation with this lumen cannula on the chest X-ray? I know it was
Generally, you do it by echo.
okay.
So the echo, you can actually see, that's a good question. Actually, echo, you can actually see that jet directed right at that tricuspid valve. So if your patient's hypoxic, that's when you call the cardiologist and they have a dual lumen and you're suspecting that, or it's just part of your workup actually when they're hypoxic with a single cannula dual lumen. You call cardiology and say, I need a stat echo to look at the direction of this jet at the tricuspid valve.
My second question is, do we sterilize patients when they're on ECMO? Or do we always do it? Do we sometimes do it?
So we try not to. So the ideal ECMO patient is someone with a cannula. I should have put this picture in, but someone with a cannula walking around. pulling their unit. Like that's the ideal. So the reason we put them on ECMO is to get them off those high uncomfortable vent settings, to protect them from lung injury, to decrease sedation, to not paralyze, and to get them up and walking. The transplant patients are a great example because they have to maintain some sort of mobility, muscle strength, things like that in efforts to get their transplant. So that's what we attempt to do with all patients. Is that possible with all patients? No, it's not. But ideally, you want to decrease sedation and paralysis. They do not, they don't have to be paralyzed or sedated if you can help it. All right, thanks guys. Thanks for working with me with the weight method. Appreciate it. I'm gonna leave that to you.
Yeah, I'm just gonna.
Thanks for switching in.
Oh, of course.
I'm like, these interviews are gonna run
Oh,
over
no.
and I'm not gonna make it.
How'd they go?